Elizabeth. I appreciate the introduction and I appreciate everybody coming out tonight for this talk. We are going to be speaking about lupus, some general descriptions about lupus, and some updates as well. Without further ado, we'll get started. First, a little bit of lupus, a little bit of history about lupus, that is. Why is it called lupus? What does lupus mean? Some of you may know this, of course, but it was first described in medical literature by a Scottish physician named Robert Willan. You see him on the far left. And there was a book describing dermatologic disease, cutaneous disease. And they described this red rash that affected people's face, sort of in a symmetric distribution, going over the cheeks, what we call a malar rash. Because of its resemblance to the fur, the pattern of colors of fur of a wolf's face, they called it lupus, which is Latin for wolf. So originally, that was the term that was used. Then they this is the 1800s. Later in the century, they noticed that the rashes that appeared on lupus tended to be red and so they called it lupus erythematosus. Erythema means red. But by the end of the 1800s, they realized it wasn't just the skin, that lupus really was a systemic disease. So it began to be known as systemic lupus erythematosus. In the past 70 years or so, I mean, lupus is really a fascinating story about the progress of medicine and how much we've come to understand really about the immune system and how it works and what happens when it doesn't work perfectly well. Really going back to the 40s, when they first developed cells that were characteristic of lupus, to understanding how it develops, to developing treatments from the very beginning of the use of prednisone to hydroxychloroquine, and eventually all the way over to this decade where they began to develop biologic agents. So the story of lupus is really the story of incredible medical discoveries, and hopefully they're going to continue. Okay, so for a brief outline for today, we're going to discuss, well, what is lupus? Let's discuss some of its epidemiology. How common is it? How does it happen and why does it happen? What do we know about that? How does it present clinically? What are the different ways in which people can present with lupus? How do we diagnose it? And how do we manage it? So let's get started. Okay, we'll start with what is lupus? So lupus is it's really a multi-systemic disease. What that means is that it affects really many different parts of the body. It's not just the skin, it's not just the joints. Almost every system can be affected by it. And this is why you really do have to be a good detective to diagnose lupus, to know when to suspect it. As they say, lupus in reality rarely reads the book. So, for example, if somebody presents with pain in the wrist, that could be, 50 things, but how do you know when it's the beginning of lupus or just some other, unrelated problem? So really you need time on your side. You need a close monitoring. You need to be able to put patterns together. And it's kind of like a joint project between the patients and the doctors and everyone else involved. Okay. So let's talk about epidemiology and impact. Oh, pardon 1 second. I see that we have skipped some slides here. Okay, hold on 1 moment. I'm going to make sure that it's showing the presentation that I wanted it to. Okay. Let's define lupus again. Okay, so it's a chronic systemic autoimmune disease. It's characterized by inflammation and immune-mediated injury, affects many parts of the body. Most typically, the skin, joints, the blood counts, and the kidneys. Okay, now let's talk about its epidemiology. Okay, how common is lupus? Okay, so lupus is not one of the more common autoimmune conditions. It's diagnosed in about 400,000 people per year. There was a 2023 systemic review that showed, interestingly, the highest incidence of lupus was in the countries listed here, in Poland, the US, Barbados, and China. Perhaps not exactly what we would have expected. In the US, you see it in about 5 to 12 per 100,000. That's based on a 2018 review. Okay, how about in the US? Who actually gets lupus? So based on 2021, and these are numbers per 100,000, you see that it's much more common in women than in men. There's something like a 9-to-1 ratio. So that already tells you something interesting about it. In addition, it's also much more common in the Black population. If you talk about incidence and prevalence, and this is per 100,000, it's 15.9 versus 5.7 and 230 versus 84.7. So it gives you some hints of, that there is a role of gender and sex hormones, and there is a role of genetic background as well that's very strong in lupus, but that's not all there is to it. And what we're going to find is there's really nothing that's not complicated about lupus. For this reason, as it is in rheumatology, we deal with sort of obscure and esoteric autoimmune conditions, but even within rheumatology, there's a specialty called lupology. So sometimes we'll refer someone to a lupologist. We say it's good to have an ologist for everything. So that's something to keep in mind. Okay, let's talk about the impact of the problem. So lupus has a lot of impact. Because it affects so many different parts of the body, it can lead to complications depending on what organ system is affected. It's very well known that lupus can lead to kidney disease. About 40% of patients with lupus develop something called lupus nephritis, which is inflammation of the kidney. That can be very serious, and 10% of those patients with lupus nephritis can go on to end-stage renal disease requiring dialysis. Lupus is also associated with a strong risk of cardiovascular disease. By which we mean coronary artery disease that can lead to problems like heart failure, heart attacks, or arrhythmias. But what's strange about it is that it can occur in patients who are a lot younger than the typical cardiac patient. And that's because the risk factors that lead to heart disease and lupus are not like the traditional risk factors. They're not necessarily risk factors of, let's say, high cholesterol or type 2 diabetes or something like that, or hypertension. It's more just inflammation. So it shows you why it's so important to detect it and to treat it, because unchecked inflammation can impact the heart. There have been seen increased risks of certain cancers in lupus, like lymphoma, and certain infections as well. The infection risk may have to do with the treatment of lupus. So we have developed much better treatments that are less likely to lead to infection. And finally, I'll just also mention that there's an increased risk of osteoporosis, which means thinning of the bone, which confers a risk of fracture. Again, you see osteoporosis in lupus patients who are much younger than the older patients in whom you might expect to see osteoporosis. Okay. Lupus is also a very costly problem. As you can imagine, anything that affects so many different parts of the body can lead to such serious complications, are a huge cost to the patient and to the healthcare system. If you look at costs by severity, the cost per patient per year of mild lupus severity, what's considered quote unquote mild, is still $13,000 per year, going up to $68,000 per patient per year. And think about the fact that there are hundreds of thousands of patients. The cost of flares can also be very costly from mild to severe. And the cost to the healthcare system and to patients, again, is astronomical. So as if it wasn't enough just to realize the importance of treating symptoms and preventing medical complications and health complications, there's also a serious challenge to the healthcare system. Unfortunately, it looks at this point as if the costs will continue of lupus because it's a very prevalent disease, because treatments are very expensive, and in general, the healthcare system is challenged. So what is the solution to that? The solution is to diagnose it early. So we need people to be able to recognize it, to diagnose it, and we need to be able to intervene and treat it early, because there's a lot of evidence that if you treat it early, you really can prevent a lot of the long-term problems. But I don't want to be a downer too much, because I want to tell you that there's a lot that's really great about lupus, and that's really improved the situation. So the survival rates have improved enormously. The 10-year survival rate in the 50s and 60s was 60%. And with the decades, it's now over 90%. So we're doing really well, and we can tell this from statistical and epidemiologic studies. We've also gotten better at diagnosing it. It used to be that we would take a cell and put it in a petri dish and apply the patient's antibodies, and 3 weeks later we would know whether the ANA was present. But now with the improvement of technology, we've gotten a lot better at having good tests that can really show us if lupus is there or not. I'll particularly mention there's a test called the AVISE. You might see it there. Which is a send-out test, which we now do, and it's really excellent in determining whether someone has lupus or not, beyond the normal ANA tests that we're used to seeing. The other thing that's really good, and I think that why things are getting better, is we've developed incredible advances in treatments. From the discovery of hydroxychloroquine, also known as Plaquenil, which is really a game changer in lupus, that those patients who take hydroxychloroquine and have lupus and stay on it, it really improves the risk of flares. It improves mortality and morbidity and all problems. We've also developed excellent medicines that control the inflammation that is lupus, and I'll mention in particular Cellcept, which has been a game changer for lupus nephritis. And also voclosporin. This is a new medicine, which also is now considered first line for lupus nephritis. We have developed biologics. Of course, biologic agents are highly specific, very fancy, very expensive medicines that really try to target the very first step in the inflammatory cascade that leads to lupus. We know already there's a lot of biologics out there for rheumatoid arthritis, for psoriatic arthritis, but the past five to 10 years have seen biologics developed specifically for lupus, and they're fantastic. They're more effective than anything that's come before them, and they are safe, and they allow patients to get off of more toxic medications like steroids and prednisone. Finally, I want to point this out, because this is kind of this is the future and the revolution in lupus. It's called CAR T-cell therapy. And CAR T-cell therapy is something that's actually used in oncology right now. It's an incredibly almost science fiction-like type of therapy, whereby your own cells are modified and trained to go after the bad guys. They go after the lupus cells, and they eliminate them. And this is still being developed. It's not ready for prime time. It's still under research, but in the past year or two, it's taken the rheumatology world by storm, because they tried it out in something like 20 to 30 lupus patients who had very resistant disease, had tried everything, and were still having very, very severe symptoms and complications. They were able to eliminate the lupus and eliminate the need for any medication. So it's almost like a cure, if I can use that word. Again, it's not ready, and there's a lot of challenges with it that remain, but it's the best thing that we've seen yet. So there's a lot of really, really neat research and findings that's making this a much more treatable condition. Okay, let's talk about pathophysiology, because this is also very fascinating. And if you understand, if we try to understand a little bit about why lupus happens and how it happens, you can also understand how to treat it and what the treatments are. So what sets off lupus? There's not one cause of lupus, and this is sort of a general paradigm for autoimmune diseases in general, not just lupus, but also you might say the same about rheumatoid arthritis or vasculitis or psoriasis or anything that we deal with. It's a combination of factors. It's your genes. There are certain genes that lead to a higher risk of lupus. It's certain environmental factors, and what those are, we try to identify based on statistics. And then that combination leads to a process that then leads to lupus. Okay, so how so? it's very genetic. If you have lupus, it doesn't mean that a direct relative will necessarily have it, but there's definitely a higher risk of relatives having it. There's a 44% heritability. There's a high correlation between siblings' risk of developing lupus from one sibling to the other. And if you look at identical twins, there's a tenfold higher risk of getting lupus if you have an identical twin with lupus. But notice what's interesting about this, that yes, very high risk if you have two identical twins, but it's not 100%. So the fact that, if you're two identical twins, you have exactly the same genes, why does one develop lupus and one not? That shows that there's more to it. There's more to it than genes. Genes are very important, but they're not the whole story. And we'll talk about that. Okay, so, well, what are these genes we're talking about? Well, look how many there are. And if it looks like gobbledygook, it's because it is. Usually, the busier the slide, the less we understand about something. That's like, that's the way it often is. So, yeah, multiple genes have been identified. Abnormalities or mutations in these genes have been found to have a correlation with development or risk of lupus. And it's interesting, if you break down what happens in lupus and the different steps, a lot of these genes are associated with a specific step. So for example, we're going to go over this a couple of times, but what is the basic problem in lupus? What is the basic process of lupus? Well, it's an autoimmune disease, and it means that your immune system that's normally there to fight off foreign entities like infections, instead of going after the infections, it goes after yourself. So it sees your own cells as something foreign, as something to attack. It's kind of friendly fire, unchecked and unhinged, as we might say nowadays. So anything that has to do with that process, for example, how do your cells recognize you from an infection? Well, if something goes wrong with that, then the inflammatory cells are going to start going after your own cells. Once that happens, what turns down inflammation in your body? Well, if what normally turns it down is not there anymore and it's on overdrive because of a genetic problem, that's also going to keep the inflammation going. So a lot of really fascinating little steps here, and each of these genes are implicated in it. Okay. However, there is something called epigenetics. Okay, so epigenetics is not genetics, but it's the interplay of environment on genetics. What that means is that you could have the perfect genetic setup. You could be primed, the perfect storm, as they say, the genes that will potentially lead you to have lupus. But if the environmental triggers are not there, if the factors that turn the light on and off are not around you, you won't develop lupus. That's what epigenetics means. It means that something has to switch on the genes and provoke them and activate them, and that may get the lupus process started. So epigenetics has to do with environment. What is it in the environment that we've seen that confers a high risk of lupus, or can set it off or exacerbate it? So I kind of listed some of the main ones here. A very well-known one is UV light. UV light is the quintessential physical factor associated with lupus. It classically triggers lupus rash and inflammation of the skin, but it can also lead to lupus flares, not just involving the skin, but internally. It causes damage to cells, and we'll see soon that if you damage the cells of the body in someone with lupus, that perpetuates a process that keeps going and that causes more and more inflammation and self-attack. So UV light is a huge one. It's recommended for people with lupus and maybe everybody to use LED lights, which don't have UV light, and to wear plenty of sunscreen. That's how you kind of protect against it. Okay, how about infections? So are there infections that cause lupus? So we can't say for sure, but we can tell you one thing, that the pathogenesis of lupus, when somebody gets lupus, is very similar to what happens when you get a viral infection. When viruses attack the body, the way the body tries to fight them off with the creation of antibodies and with the release of certain mediators like cytokines like interferon, which we're going to talk about, that's almost exactly what happens in lupus as well. The difference is, in lupus, it's not attacking a virus, it's attacking yourself. And in lupus, the process keeps going. But we've learned a lot about lupus from viral infections. It turns out that there are certain infections that have a higher risk of setting off lupus. One of them is EBV, Epstein-Barr virus, which is associated, of course, with mononucleosis. And there's others as well. Okay, going on to more toxigenic environmental risk factors, that could include chemical factors like smoking. Smoking also is associated with damage to cells, which can stimulate lupus. Certain environmental exposures like silica, petroleum solvents, and there are medications. There's now over 100 medications that are thought to have a role in potentially provoking lupus. In those patients who are genetically predisposed, if you get exposed to this medicine, they could totally set it off. So, I'll mention the more commonly used ones include hydralazine, which is used a lot for hypertension and heart disease, and also minocycline for acne. There's more as well. Now, just because you take hydralazine doesn't mean you'll get lupus, but in certain people, that will lead to its association. The last really important environmental risk factor I want to mention, and there's a lot more, is the role of sex and gender and hormones. So what role does that play? So, it should have struck you that why is it so much more common in women than in men? Again, the ratio of women to men is like 9-1. So that suggests that sex hormones and perhaps estrogen in particular might be playing a very strong role. The interesting thing is that if you look at a pediatric lupus of boys versus girls, it's not the same ratio. So it really is something about post-puberty hormonal environment that leads to it. And there's been a lot of studies that have borne this out. In other words, exposure to estrogen, prolonged estrogen, is thought to confer risk of developing lupus, of worsening lupus flare, and of perpetuating lupus. There was a very famous several decades long study called the Nurses' Health Study, in which they followed the health patterns of nurses, what medicines they were on, and what conditions they developed. And this is where they got a lot of their information. They found that women on, that first of all, lupus is much more common before you hit menopause for younger women, in which there is more estrogen. Secondly, the rates of lupus go down after menopause when there isn't as much estrogen around. And to add to that, women who took hormone replacement therapy with estrogen in it were likelier to develop lupus and have lupus flares. So estrogen definitely has a role here. I also want to mention that estrogen also has a role, a potentially dangerous role in promoting blood clots and thrombosis, which is known already, but that has impact on lupus, because some lupus patients have higher risk of blood clots and thrombosis when they have the so-called antiphospholipid antibody syndrome. So patients like that should not be exposed to estrogen, is the bottom line. Okay, so these are some of the factors associated with setting off lupus. Okay, well, what's going on in the immune system? So this is also, and we could do this all day and have a whole lecture on it. But I think if I had to sort of, characterize the three basic things, the immune system is very activated, and the main players in the immune system are B cells and T cells. Now that becomes important because the lupus treatments antagonize B cells and T cells. They try to control them. They try to diminish their high state of inflammation, and that's how they calm the lupus down. One of the characteristics of lupus is autoantibodies. Everyone's heard of the ANA, having a positive ANA. That's one of the hallmarks of lupus. So that's what happens in the immune process. And finally, I may have mentioned this before, there's something called interferon, and this is something that's become more and more focused on in the past number of decades. As they see it, it plays a huge role in the process that is lupus. It's basically a cytokine that causes activation of all these cells and keeps it going. Okay, so if I had to sort of, try to really, really simplify an extremely complicated process, lupus has something to do with the way cells die. Okay, so how does this work? If you look at the slide on the left, cell death, quote unquote, is called apoptosis. There's a normal process when cells age, when they're ready to die and be recycled, they gradually shrink and they form blebs, and they're cleaned up by the cleanup cells. That's the left. The right, what happens with lupus is too many cells are dying. It causes the premature death of many cells, and also these dead cells are not cleared out. they kind of hang around. Because they hang around, the debris catches the attention of the immune system. The immune system sees things it's not used to seeing. So suddenly it says, well, why is there all this debris there? Oh, it must be an infection. I better go attack it. So this starts an attack process by the immune system against your own self, against your own debris that's not being cleaned up properly. And that's what generates the autoantibodies and the lupus process. And if you imagine all of this is in a soup and the main ingredient to the soup is interferon. So I'm simplifying it like scandalously, but I just, these are the concepts. Again, we talked about B cells and T cells. B cells are important because they generate the antibodies. So again, I told you that before, if you think about the model of a virus, that's a little bit similar to the model of lupus. And if you think about COVID, you may remember at the time of COVID, I say the time of COVID, it's not really gone. Everyone was checking COVID antibodies, you know. Why? Because, you know, the COVID virus generated antibodies against itself. So similarly, lupus generates antibodies against your own cells. And the generators of antibodies are the B cells, which you see here. What are the T cells? T cells are cells that work with B cells and they set off the alarm. They activate the B cells. So we got B cells and T cells. We got production of autoantibodies here. I'll just show it in a cartoon one more time because I think it's an interesting concept. On the right side, you have the normal process. The cells break down, they're cleaned up, they're put away, so everything's fine. On the left side, the dead cells are not put away. There's too many of them. They're not cleaned up. So antibodies form against them, and then the antibodies start attacking various parts of the body and lodging in various parts of the body, and that is what causes rash, arthritis, kidney disease, and what leads to lupus. So here's just showing that once the autoantibodies form and there's too many of them, they start causing problems with the rest of the body. Okay, all right. Now, what can we talk about how lupus presents? Again, very challenging because it has many manifestations. It's really a great masquerader. You know, unlike autoimmune thyroid disease, it's only going to present with a problem in the thyroid, you know, but lupus can affect any part of the body. So it's always tricky to ask yourself, well, what is it we're dealing with? Is this part of a pattern? Many organs are affected in lupus. We'll go through them. I think the most common set of manifestations, you would have fever. You can see hair loss. Very often patients will have canker sores, oral ulcers, joint pain and swelling, arthritic symptoms, and rash. Again, if you take any one of these by themselves, it could be something else. But taken together as a pattern, you begin to suspect lupus. Okay. There are also abnormalities in the blood work. So when your primary doctor checks your blood tests, you know, they're looking at your blood counts, they're looking at your liver, they're looking at your kidney and urine. Normally they're fine and there's not a problem. When you have lupus, there's something going on there. You can see the counts are low. They tend to be anemic. Their white blood cell count is low. The kidney might be off. When you do a urine, there might be cells and protein in the urine. So you can see something's going on. There's an inflammation in the system. This is even before you order any special tests looking for lupus. So when you're suspecting lupus and you want to say, okay, does this person actually have it? I'm seeing a pattern here. I'm suspicious. I want to find it. You know, then you see the presence of autoantibodies. So the ANA is the most common autoantibody, the anti-nuclear antibody. And again, that tells you what it is and how it's generated. It's an antibody that was formed against your own cell nucleus because the nucleus was exposed in debris that wasn't cleaned up, to go back again to the concept. But there's a lot of other antibodies which you may have heard of, especially if you're sort of interested in lupus. The DNA antibody, anti-Ro, anti-LAW, anti-phospholipid, they all have very specific associations, which is what's interesting. The DNA antibody, for example, is associated with lupus nephritis. The Ro and LAW antibodies are associated with something called Sjogren's, which is dry eyes and dry mouth, often seen in association with lupus. The phospholipid antibodies, that's the last one, that has associations with problems with pregnancy and also with blood clots. Now, I don't want anybody to get freaked out because, as we'll see later, just because you have an antibody doesn't mean you have lupus, and it doesn't mean you're going to have, you know, these kind of scary complications. A lot of people have autoantibodies and nothing else. And what that means is that for some reason, the immune system is activated. It's kind of reacting against itself. but it's not necessarily come to the point where it's going out into the body and wreaking havoc. So you have to be careful that, this doesn't make the diagnosis, but it supports it. Okay, let's look a bit at some of the manifestations. So here you have cutaneous lupus, which is the classic skin lupus. Okay, so it often can present acutely, meaning like very quickly, people can get a lupus rash. Sometimes over the course of weeks, 4 to 6 weeks, and sometimes it can be chronic. There are classic patterns like the rash over the face. That's the top panel. It can cause what's called an annular rash. Annular means like a ring, which you see in the middle panel. And the lowest panel is what they call discoid lupus. And this can happen in people who have it for very long periods of time. It causes scarring. It causes these white plaques that scar, and it can be one of the forms of lupus that's associated with hair loss. Now, you might say, oh my gosh, I've also had a rash on my face. Does that mean I have lupus? Probably not. So the more common cause of rash on the face is something called rosacea, which is another inflammatory rash, has nothing to do with lupus, but for sure it can worry you if you have lupus in mind. How do you tell one from the other? Well, get a good dermatologist. That's the short answer. But there are certain patterns of one versus the other. And I think one of the famous distinctions, and again, don't quote me on it because, sometimes, the skin doesn't read the book. But with lupus, they have what's called nasolabial fold sparing. In other words, this area right here between the nose and the cheek is usually not affected by the rash. You can see that in the left panel. On the right panel, the rosacea rash just goes right through and it's just everywhere. It's confluent. That's one way in which they sometimes try to tell one from the other. Okay. As we said earlier, lupus can cause joint disease and arthritis. Sometimes it looks like rheumatoid arthritis, but the difference is that the joint deformities you might see with lupus are reducible. In other words, although it's bent, you can kind of put it back into shape. And also, when you actually get X-rays of the hands on lupus patients, they don't have erosions or damage to the joint the way patients with rheumatoid arthritis might. So yes, it causes joint pain and swelling, but it's a very different pattern. Okay. Lupus can affect the lungs and heart most commonly. And now I'm not talking about heart disease like we said before. When lupus itself attacks the lungs and heart, it usually attacks the lining of the lungs and the lining of the heart. It can cause a little fluid in the lung. That's called pleuritis. So that may present with some shortness of breath or chest pain or fever, but it's not a heart attack. It's fluid and inflammation around the lung or heart. Pericarditis is more common than lupus. Sometimes you need an echocardiogram to see that. We mentioned before that blood tests might look off. They might look a little abnormal in lupus, particularly the white blood cell counts and the red blood cell counts and the platelets. So it's seen very commonly. So why is that? Well, just like the autoantibodies of lupus can cause inflammation of the skin or the joints or the kidney, they can also attack the red blood cells and platelets and white blood cells themselves. So it comes from that sometimes. Sometimes when there's too much inflammation in the body, the bone marrow, which produces cells, doesn't produce it well. Sometimes iron is consumed, so people have low iron. And sometimes, when people have low counts, it could be from a virus or it could be from medications. And it could be from some of the very medications that are used to treat lupus. So something to keep in mind as one of the manifestations. Okay, lupus nephritis. We've spoken about it before. 40% of lupus patients will have lupus nephritis. There are various types of it. There's various degrees of severity. This is one of the reasons why it's very important for patients with lupus to follow up very regularly with their doctors, because you can sort of get early signs of lupus nephritis by looking at the urine. If you test the urine, you make sure there's no cells, there's no protein, that it's not rising. If you really, really are concerned that an active inflammatory process might be going on in the kidneys, you treat it, and you sometimes need a kidney biopsy to really see if it's there. But the lupus nephritis is something we have excellent treatments for. Of course, we would much prefer to not let it develop at all, and that's what we try to do. And again, it's associated with the DNA antibody in particular. With lupus, there are often pregnancy issues. Again, the hormonal changes that happen in pregnancy means that sometimes lupus will flare up during pregnancy. Also, whenever a woman with lupus becomes pregnant, we want to watch it very closely. We want to make sure they don't have antiphospholipid antibodies, which are a subset of antibodies seen in certain lupus patients. Again, they have associations with fetal loss or miscarriage. They have associations with blood clots as well. And if a woman has antiphospholipid antibodies, she has to see high risk fetal maternal medicine and sometimes receive anticoagulation like heparin. The other thing I want to mention with regards to lupus and pregnancy is, again, we were talking about different autoantibodies. Certain patients with lupus have the Rho-Law antibodies. And of course, if you can't remember the names or it's all confusing, don't worry about it. A physician will always be happy to explain it to you. The Rho-Law antibodies are also very important to monitor if a woman becomes pregnant because they can lead to neonatal lupus. The antibodies are actually transmitted to the fetus. And so the way we deal with that is we have fetal echoes done. So it's a rare thing, but it's something to be aware of. Okay. Finally, I'll just mention there's something called neuropsychiatric lupus. Patients with lupus can get very disturbing side of neurologic manifestations like headache, like seizure, or sometimes cognitive impairment. It's very difficult to diagnose. There's no specific test for it. And sometimes, a migraine is just a migraine. It doesn't necessarily mean that it's from the lupus. So how do you know when one is causing one versus the other? It's very hard to tell. But the most common neurologic manifestation of lupus is probably peripheral neuropathy, meaning patients with lupus sometimes have numbness or tingling or burning pain in their hands and feet. Okay, so how do we diagnose lupus? Okay, now that we went through the different manifestations, well, there are formal ways to diagnose it. Okay, there are criteria that were developed in 2019. They use these criteria really for studies. If you want to enroll a patient in a clinical study, they have to check all the boxes on these criteria. They look enormously complicated. Again, welcome to the world of lupus. But basically, the very first criteria, if you look to the top, is you need a positive ANA. So if you don't have a positive ANA, it's very unlikely that you have lupus. It's not impossible, because sometimes ANAs are negative in the beginning and positive later, but it's much less likely. Once you have the positive ANA, according to this classification table, you need 10 points. And you see, you get different numbers of points depending upon what's involved. If you have joint involvement, you have 6 points. If you have canker sores, you have 2 points. If you have a rash, you can get another. So if it adds up to 6 plus the ANA, that's kind of the diagnosis of lupus. But that's the more formal, by the book way. Sometimes, it's more of a gestalt and it's more of a feeling. Here's a list of all the autoantibodies, how sensitive and how specific they are for lupus. We talked about a lot of them: the DNA with lupus nephritis, the phospholipid antibodies with thrombosis and pregnancy issues, the Rho and Law with Sjogren's and neonatal lupus and rash. So, once you suspect lupus, you start ordering the autoantibodies. And here I sort of tried to summarize it. So if you have symptoms that are sort of affecting various parts of the body, like the joints causing arthritis, like rash, like low counts that you might notice on the blood work, like an abnormal urine. So then you're already beginning to suspect it. And you would have a rheumatologist do a physical, do a history and physical, ask more questions, and probably send more tests. And the tests that we send are these autoantibodies. So that's the basic feel of lupus. It's multisystemic. It causes inflammation in the skin and joints, and it's associated with autoantibodies, if I had to summarize the top 3 things. Now, sometimes we're still not sure, because again, lupus can, although it could have 12 different manifestations, sometimes only 1 or 2 show up. So how do you know if that's really the beginning of lupus or something else? Again, difficult. Or what if they only have 1 blood test but not the other? And the interesting thing is that, they can present with autoantibodies at different points in time. For example, the DNA antibody is only present in 30% of patients in the beginning of diagnosis of lupus, but sometimes within 5 years, 75% of patients will have it. So how do you deal with all that variety and all that diversity? The answer is it's tough. But what we can do when we're not sure is we sometimes go ahead with biopsies. If someone's skin is very inflamed, you're trying to figure out if it's a lupus rash, you can get a skin biopsy and it will often show classic findings. And that's probably all you need. Similar with the kidney. If someone's having a kidney issue, you're not sure if it's lupus nephritis or not, because that makes a big difference with how you treat it. You get a kidney biopsy. Vasculitis is likewise. So these are other ways to do it. Okay, back to the ANA. I just want to mention again, positive ANA does not mean that it's definitely lupus or definitely a disease. The estimation is that 20% of the healthy population has a positive ANA. So what matters is how high is the ANA? Number one. Number two, is it associated with the symptoms that we associate with lupus? And number three, have we really ruled out other things? Because there's a whole bunch of other things that can give you positive ANAs, like infections, allergic responses to drugs, and also other autoimmune conditions. So if you asked me, what's one of the most common non-lupus conditions that can cause a positive ANA? It's thyroid disease. So if you have thyroid disease, you have a positive ANA, but you don't have the other features of lupus, it's not lupus. So that should be hopefully somewhat reassuring, because I know it can be scary to get back up a test that says you have a positive ANA. Remember that lupus can resemble a lot of things. Again, great masquerader, a lot of things, a lot of other entities and conditions have symptoms that are very, very similar to lupus. So we want to be ruling out thyroid disease, rheumatoid arthritis, fibromyalgia, infections, and I'll say one more thing, that if you look at this middle panel here, there's something called undifferentiated connective tissue disease. This is one of the favorite phrases of rheumatologists, because a lot of the time we can't really put an exact label on it. So if you have someone that has one or two features of lupus, maybe, but not the others, but you're convinced, this probably is autoimmune, we don't call it lupus, we call it undifferentiated connective tissue disease. And, we may or may not want to treat it anyway, depending on what the symptoms are, how much you are affected by them, and, how concerned we are that it might progress. Okay. So how do we manage lupus? Again, we live in a great age because we have a lot of options. What's the goal of lupus treatment? Well, cure would be amazing. Right now, the treatments we have don't really lead to cure, with the exception of that incredible new development that we'll see if it really does cure it. But most of the time, lupus has to be kept at bay. Lupus is chronic. It waxes and wanes. It can flare up. You always want to keep it under very good control. So you use your treatments to minimize disease. You use your treatments to prevent it from progressing and causing damage. And above all, you want to improve quality of life. I mean, lupus is something that's very hard to live with. It causes chronic pain. It causes chronic fatigue. It causes malaise and not feeling well. Imagine feeling like you have the flu all the time. That's often what a lupus patient might feel like if they're not on the right treatment. So it's clear why we have to treat it. Many treatment options. This just shows you how many we have right now, not to get confused or intimidated, but what we treat in lupus depends on what the problem is and how severe the problem is. And we'll go into that a little bit more. Okay. So here I want to put in a plug for hydroxychloroquine. Hydroxychloroquine, also known as Plaquenil. So it really is the standard of care for all lupus patients. It's something that controls the immune response. And it's a relatively well-tolerated and safe medicine. And it's the standard of care. Anyone who has a diagnosis of lupus, the belief is that right now they should be put on hydroxychloroquine and Plaquenil, even if they don't feel like they have symptoms, even if they feel fine, because it prevents sudden flares, sudden attacks, sudden explosions of lupus inflammation that could happen. And it has shown to reduce mortality, reduce flares. It's really like, unless you have a reason that you can't take it because of a side effect, an extremely important medicine to take for lupus. Now, the main thing you have to know about it is when taken for very long periods of time, you have to have your eyes checked because it can cause retinopathy, which is very rare. Once a year, you see ophthalmologists. They do something called a visual field test. And as long as they clear you, you're good to go. So that's very important. Now, the next phase of lupus medicines were the so-called immunosuppressive disease-modifying agents. These are medicines you've probably heard of. They use them a lot in other conditions like rheumatoid arthritis or transplant. They're basically oral pill medicines that control and diminish the immune response, and in doing so, improve lupus. Methotrexate, the third one, is used a lot for lupus arthritis. Mycophenolate or Cellcept, as I said, is like standard of care now for lupus nephritis or kidney disease. Imuran or azathioprine can be used in lupus heart disease or in lupus rash. Here are our friends, the B cells and T cells again. And I want to show you them because the revolution in lupus has really been the development of biologic agents. So biologic agents, again, they go after very, very specific markers or molecules that they literally go after the light switch that when switched on leads to the whole cascade and domino effect that leads to lupus. So there's three main targets that they've developed in the past 10 to 15 years. One is targeting B cells, one is targeting T cells, and one is targeting interferon. So I'll show you what we mean. Since 2011, and most recently in the past 5 years, the FDA has approved three new therapies for lupus, which is huge because before 2011, the last time anything was approved for lupus was 50 years ago. And the way we treated lupus was we borrowed from other conditions. We borrowed medicines using them off label, but now they are FDA approved. So one of them, the first on top, is belimumab or Benlysta. You may have heard of Benlysta. It's a biologic medicine that's given as an injection or infusion. In 2011, it was approved for general lupus. In 2020, for lupus nephritis. The middle agent is voclosporin. This is something that was approved several years ago. This is a tablet or a pill, but it's now considered almost first line in lupus nephritis. Extremely effective in preventing progression of lupus nephritis and treating lupus nephritis and really saving kidneys. And the third is anifrolumab. This is an IV infusion. It's called Safnello. It's a once-a-month infusion which targets interferon. We mentioned interferon before as a very inflammatory cytokine that's causing a lot of the problem in lupus. This antagonizes it. Okay, so let's talk about it more. Here is Benlysta and how it works. They say it puts the B cells to sleep. So it targets a molecule called Bliss, which turns on and activates the B cells. Again, too much B cells is bad in lupus, so this kind of stuns that and quiets them down. And in doing so really helps, especially with very severe refractory joint disease and skin disease. And now, even more recently, lupus nephritis. So Benlysta is something that has been approved now for lupus nephritis. And it's really a game changer. So if you are already being treated for lupus nephritis, but the medicines you're on are either not working properly or not tolerated very well, Benlysta is often added. Now, I've said a lot about lupus nephritis and a lot about treatments. How do you know when to use one versus the other? And that's a question we haven't sorted out completely yet. However, I would say that Benlysta is used for lupus nephritis, especially when a lupus patient has other things going on as well, not just lupus nephritis. So lupus rash, lupus arthritis, very severe, lupus fatigue. It's added on, and it's an extremely effective addition to the regimen. Not just that it's effective, but it's also safe, and it allows you to get off the traditional medicines that they were using in lupus, like prednisone. This is LUPKYNASE, voclosporin. I mentioned it before. It's also a very, very effective lupus nephritis medicine. What it's particularly good for is lupus nephritis patients who have very, very high levels of protein in their urine. That's a marker of inflammation of the kidneys. And when patients are already on standard of care, like steroids and Cellcept, and they still have ongoing inflammation with lupus nephritis, and there's a lot of proteinuria, but they don't necessarily have other manifestations of lupus, like rash or arthritis, we'll add this medicine, voclosporin, which is really remarkably effective. Here's a cartoon of Safnello. You almost need a PhD to understand it, but the idea is you have this little orange molecule called interferon, which is causing a lot of trouble and activating inflammation. For interferon to work, it needs to bind to a receptor. And anifrolumab or Safnello, the interferon antagonist, goes against that receptor and prevents interferon from binding and doing its thing. It's kind of like it prevents your hand from reaching the light switch, if you want to understand it that way. Very effective medicine for lupus. activity, and it's been found to be particularly good for lupus rash. So patients who have resistant lupus rash, despite Plaquenil, methotrexate, even Benlysta, they think that this is a game changer. You get it as an IV once a month. It acts relatively quickly. And what I'll show you in this slide, although I know I'm going quickly, is that it lasts for a long time. So here's 4-year data. You see 2 graphs here. The green above are those patients who did not get the interferon antagonist Safnello, and the ones in red did get it. And this is a measure of lupus activity. So you can see that the ones who got the red, the treatment, their lupus activity went down and stayed down over time. So very, very effective, and it's a nice tool to have. I mentioned before CAR T-cell therapy. I mean, this is really something that we're going to have to follow. Right now, it's a very complex therapy. It's a little bit like getting a bone marrow transplant. So it's clearly not for everybody. It requires a lot of infrastructure and resources. However, for those patients who have lupus so severe, God forbid, that nothing's working for it and it's marching on and progressing and everything's been tried, this has been able to reset the system. It's like a reboot. And so these patients do incredibly well and no longer need medications and actually go into remission. Of course, there's more complexities with it, but I just want to mention that it's something to look out for in the news, this so-called CAR T-cell therapy. Okay. So to summarize a lupus treatment approach, Plaquenil is king. You have to take Plaquenil as long as you tolerate it. You don't have an allergy to it. It really reduces problems over time. In the past, as lupus has been treated with steroids and prednisone because that is the quickest way to reduce inflammation, but they think they're very bad over time. You really want to try to minimize. They lead to infections, hypertension, diabetes, osteoporosis. It's better to use the other tools that we have in place of prednisone. There's numerous medicines we have out there, from the traditional ones like methotrexate and Cellcept to the new biologics like Safnello and Benlysta. When to use what, you have to ask your rheumatologist, but really, really very exciting prospects. And I just wanted to say, don't forget, there's a lot of measures you can take, not just with medicine, to minimize and improve risks of lupus. Avoid UV light if you at all can. Put lots of sunscreen if you're going outside. They say vitamin D is an important factor in lowering risk of lupus and lupus flare, because vitamin D is key for the immune system to be healthy. So you should be taking vitamin D. You should make sure your levels are 40 or more with your doctor. Get your updated vaccines, because you want to keep yourself protected as much as you can from infections. Sleep, reduction of stress, and healthy diets. Especially the so-called anti-inflammatory diets that you hear about or read about, like the Mediterranean diet. Omega-3 fatty acids are supposed to be very good anti-inflammatories, by the way. Walnuts. Think walnuts. Handful of walnuts a day, they say, is good for longevity in general, and specifically for things like lupus. And stress reduction has a huge role as well. Before we end, I just want to put in a plug that we do run clinical trials here at Valley in the rheumatology division. So right now we're investigating a new medicine for lupus, which is supposed to be very effective for lupus patients who have a very active rash and very active arthritic symptoms, despite getting the normal medicines like Plaquenil. It's called deucravacitinib. It's also called Sotyktu. It's actually a medicine that's already approved for psoriasis. It's already out there on the market, so it's not totally new, but it's found to be potentially very, very effective for lupus. So if you're interested, or someone has said you might be a good candidate for it, please call us at the number below, because we're recruiting patients for this study. Okay, let's do the take-home points. Lupus is a complex multisystemic disease. It affects many, many different things. It can be at once, it can be one at a time. It makes it very difficult to diagnose. But if there's any questions about it, you should see your rheumatologist, and you should be followed closely, because once it's diagnosed, if it's treated the right way, you can avoid long-term complications and live a full and healthy life. And we're also lucky to be in an era where there's extremely exciting new treatments on the horizon. So thank you very much, and thank you for your patience, and we'll take some questions.
Thank you, Dr. Zader. That was very interesting. So we have a couple questions coming in. The first one, when on prolonged steroids for lupus, do you find adrenal insufficiency a challenge?
Yes, that's a great question. That is one of the complications of long-term steroids. If you've been on a constant dose of steroid, I would say for more than 1 to 2 months, or more, there are ways to test for whether adrenal insufficiency is present. And that is one of the reasons why you can't just stop steroids in someone who's been on it for a long time, because the body has to produce its own natural steroids. It stops doing it when you get prednisone from outside. And so then you get what's called adrenal insufficiency. But there are tests that we do together with the endocrinologists, and we can check cortisol levels. And that's why we try to taper prednisone very slowly so as to give your body a chance to regenerate the steroids. But I would say after 4 weeks, you already want to be very careful about it. Certainly 3 to 6 months.
I was so enthusiastic to start asking you questions. I forgot to remind people if they'd like to ask a question, you can put it in, or they can put it in the Q&A portal located at the bottom of the screen. Um, I had a question actually. Um, are there are there common signs that someone with lupus would experience before a flare, like they can prepare themselves before a flare comes
Well,
up?
yes. You know, what usually precedes a flare is what they call constitutional symptoms. Feeling very fatigued and not being sure why, almost like a pre-viral, you're kind of almost about to get the flu, feeling aches of the muscles and the joints. Also fever, you can get a low-grade fever, and that's one of the signs of inflammation of lupus. And that's, by the way, one of the ways in which you distinguish lupus from other conditions, because, for example, someone who has a lot of joint pain or arthritic pain, that could also be rheumatoid arthritis. But in someone with rheumatoid arthritis will never get fever. Of course, once the classic things happen, you'll start seeing rash and other things. You can see hair loss that begins to happen. You can see the development of canker sores. These are sometimes warning signs that, there's inflammation going on. So when there's ever a question, we can very quickly by blood work figure out what's actually going on systemically.
And when a flare happens, does it have to just kind of run the course or
Right. That's a good question. No, like one of the things about lupus is that the body doesn't usually have an ability to overcome the flare, unless there was something driving it, like UV light exposure, let's say extreme stress, or you just weren't getting enough sleep because of a work obligation or something like that, or some other medicine, an antibiotic that someone put you on that was setting it off. When that stimulus is gotten rid of, the lupus can get better. But if the stimulus is not so clear, if it's your own body generating a response for reasons that we don't always understand, you can't really overcome it unless you intervene. And sometimes that intervention could be just Advil, taking like a simple anti-inflammatory, or sometimes you have to hit it hard with prednisone or something like Plaquenil. One of the reasons why Plaquenil is so urged, by the rheumatology community, is because it keeps the bad inflammation down, the self-reactive inflammation at a certain level away from your own cells, and therefore it reduces the risk of flares significantly.